Now, let's pay attention. Vitiligo is an acquired pigmentary disorder of the skin and mucous membrane, which is characterized by depigmented circumscribed macules and patches. So, there are important terms here. Number one, it is acquired type of disorder. That's the first thing. Second, in this condition, there is depigmented area which develops on the skin, and they are mainly patches. Okay, they are mainly patches. Now, see here. The condition is frequently associated with other autoimmune diseases. That's why we call it marker of the autoimmunity. And this is the important point for the doctors and medical students, because once a patient comes to you with vitiligo, you should take a good history to find out whether there are other autoimmune diseases or not, like some thyroid disorders, okay, probably type 1 diabetes, myasthenia gravis, Addison's disease. So those history should be asked quickly. And if some of the symptoms are there, then you should go for certain investigation to confirm it. Vitiligo is a progressive disorder in which some or all of the melanocytes in that affected skin are destroyed. This is the basic mechanism of vitiligo. That's why it is acquired one. Autoimmune mechanism is responsible for the destruction of those melanocytes. Vitiligo affects 0.5 to 2% of the world population, and the average age of onset is 20 years. Means quite young people, okay, are suffering from it. Means it starts from the young age. Look at this picture here. Okay, we see this type of patients day by day. Okay, many of the people are developing it, and with one look, you can say yes, it looks like a case of vitiligo. It is such a characteristic feature. Look at these depigmented patches here. These are large patches, depigmented one. Let's talk about what is the pathogenesis of vitiligo. Although several theories have been proposed about the pathogenesis, the precise cause remains unknown. And it is related to both genetic and non-genetic factors. Non-genetic means environmental one. There are absence of functional melanocyte in the vitiligo skin, and this is the main problem. Now, we are going to talk about how these melanocytes are getting destroyed. So these are different hypotheses or proposed mechanism. The autoimmune mechanism has more weight than others, or it has more logic than others, but some other hypotheses also exist, and they are cytotoxic mechanism, intrinsic defect inside the melanocyte, oxidant antioxidant mechanism, as well as neural mechanism. In the last class, we talked about that already, but let me revise, because we have enough time to revise this a bit. The autoimmune destruction of melanocytes says, okay, this is autoimmune disease where melanocytes are destroyed by humoral and cell-mediated immunity. And another important evidence to support this is there are so many other autoimmune diseases which occur in the same patient, and these are the example for you. Quite a catchy question from the examination point of view. Now, how the teacher asks you, can you tell me some of the examples of autoimmune disease or some of the examples of organ-specific autoimmune disease, like that. So from the thyroid gland, see there, Hashimoto thyroiditis and Graves' disease. Okay, other endocrinopathy like Addison's disease and diabetes. Addison's from the adrenal gland, diabetes from the pancreas. This is type 1 diabetes, not type 2. Alopecia areata is a skin problem again, a dermatological problem. We are going to talk about this in our next class. Alopecia, this is hair loss. Okay, autoimmune cause of hair loss. Pernicious anemia affects the stomach, and inflammatory bowel disease infects the GI tract. It depends which one you are talking about, ulcerative colitis or Crohn's disease. Crohn's disease may affect the whole GI tract, whereas ulcerative colitis mainly affects the colon. Psoriasis, we already talked about that. And autoimmune polyglandular syndrome is known as MEN syndrome. multiple endocrine neoplasia syndrome, type 1, type 2A, and 2B. There are different types. So these are the good example here. Another evidence is there is presence of circulating antibody in case of vitiligo, and then if we take a biopsy, okay, we can get all these CD8 T cells which are actively destroying the melanocyte. Now let's move on. Some other pathogenic mechanisms or hypotheses are intrinsic defect of the melanocyte. Now, what that tells us, there is early apoptosis of melanocyte in a patient with vitiligo. That means it is already genetically programmed type of destruction. Okay, that is known as apoptosis. They are dying because of that mechanism. The third one, which is mentioned, is antioxidant disturbance in the melanocyte. Now this oxidant stress will cause production of free radical, and these free radicals are very damaging for the melanocyte. At the same time, there is decreased amount of antioxidant like superoxide dismutase or catalase. These are the enzyme which acts as an antioxidant. So more destruction and less opposite mechanism which leads to destruction of the melanocyte, leading to vitiligo. Let's move on. Now, so some clinical features of vitiligo are, you already know, you have already seen that picture. There is a melanotic macular patch surrounded by healthy skin. This is a patchy type of distribution, the whole body is not affected usually in case of vitiligo. So patchy type of involvement where there is no melanocyte. It depends on the skin color of the patient. Skin color. If the person is relatively white skinned or fair skinned, then it is difficult to visualize sometimes these depigmented area. But if the person is having brownish or relatively black colored skin, then it is very, very easy to note those amelanotic areas. The lesions are not readily apparent in lightly pigmented individual, but if we do wood lamp examination, then we can detect, yes, something is wrong there, okay? And we examine thoroughly or properly, and then disease can be diagnosed. Now, let's move further, okay? Let's talk about some other clinical features of vitiligo. The initial lesion occur most frequently on the hand, forearm, feet, and face, and it favor a perioral and periocular type of distribution. This is quite early, and this is very common type of distribution. Around the mouth and around the eye, perioral and periocular distribution. And how it is seen? Depigmented area around the eye or around the mouth. Vitiligo lesion may be localized or generalized. Okay. Localized vitiligo is restricted to one general area with a segmental type of distribution, and generalized vitiligo implies more than one general area of involvement. It is not, the whole body. Please don't, understand like that. That means, both side of the body, there is a involvement. Means more than one area may be affected, and this is known as generalized. Localized means one patch somewhere. Generalized means multiple patches are present in different parts of the body. This is known as generalized one. In this situation, the macules are usually found on both sides of the trunk, either symmetrically or asymmetrically. And this generalized variety is slightly more common than the localized one. Let's move on. The most common site of vitiligo involvement are the face, neck, and scalp. Face is very common. And many of the most common sites of occurrence are areas subjected to repeated trauma, like bony prominence, we suffer from repeated trauma in the bony prominence, like elbow, extensor aspect of the forearm, ventral aspects of the wrist. When you are working on your laptop or computer, remember the ventral aspect of the wrist commonly comes in contact with the table edge. Okay, dorsal surface of the hand, and even a digital phalanges. So in this area, vitiligo patch may develop. Look at this picture. Okay, see here, look at the dorsal aspect of the hand here, a very typical one. And look at this, this is the generalized type of distribution. See, on this side of the body, the vitiligo patches are found. On the other side of the body also they are found, though there are a lot of normal areas as well. Okay, so this is a very common type of presentation. Neck is also affected, anterior part of the chest or lower part of the neck is also affected, here side of the chest, and even episternum and anterabdominal wall. I can see also on the antecubital fossa on this portion, also here. So this is a clear-cut case of generalized type of vitiligo. Now some other pictures. Look at this big patch here, and in this female, there is again generalized type of vitiligo. Okay, thorax or chest wall, I should say, neck and abdomen, all of these are affected. Vitiligo often occurs around the body orifice, such as the lips, genital, gingiva, areola, and nipples as well. Some of the patient may present with leukotrichia. Leukotrichia means white type of hair. Leuko means white, trichia is hair. So white hair. Okay, because they are depigmented, they lose the pigmentation, and this is one type of presentation. Vitiligo of the scalp usually appears as a localized patch of the white or gray hair, but total depigmentation of all scalp hair also may occur, though it is a bit of rare type of presentation. But this patchy type of white or gray hair is a common presentation in case of vitiligo. Scalp involvement is the most frequent, followed by involvement of the eyebrow, pubic hair, and axillary hair respectively. So any hair on the body may be affected in this case. Most common is a scalp. After that, eyebrow, even pubic and axillary hair can be affected. And if it occurs in the female, that particular female or even male, it doesn't look good, isn't it? The eyebrows are turning white very early. A patch of the scalp here is turning white or gray very early. This is not a good cosmetically. Leukotrichia may indicate a poor prognosis in regard to repigmentation. Spontaneous repigmentation of depigmented hair in vitiligo does not occur. So we need to go for certain therapy here. Okay, we cannot say, oh, it will come back again, the black hair come back again later on. Nothing like that here. Now, let's move further. Let's talk quickly about what are the types of vitiligo, though you already know what are the different types. Okay, in the clinical feature, we already talked a little bit about that. Localized vitiligo is one. Localized. And under that heading, we have focal, we have segmental, and we have mucosal. The focal is characterized by one or more macules in one area, most commonly in the distribution of trigeminal nerve. That means on the face. Trigeminal nerve has 3 divisions. What are the 3 divisions of trigeminal nerve? What are those?
Mandibular, maxillary,
ophthalmic, mandibular, and
ophthalmic.
Yes, ophthalmic, maxillary, and mandibular. You're right. Ophthalmic, maxillary, and mandibular division. These are the 3 divisions of the trigeminal nerve. So in their distribution, focal type of vitiligo may occur. Segmental. This type manifests as one or more maculae in a dermatomal pattern. Now, it occurs most common in children, and this type of vitiligo is not associated with thyroid or other autoimmune disorders. So a little bit exceptional type of situation. Dermatomal pattern, but the typical amelanotic patch is again seen there. So it is not difficult to diagnose. Dermatome is a part of the skin which is supplied by one spinal segment, that is called dermatome. Please remember that. And mucosal are the mucous membrane which are affected. Now, what about the generalized one then? They are acrofacial, they are vulgaris, and they are mixed. Now, acro means distal part of the limbs, acro or acral part. Facial is around the face. So depigmentation occurs on the distal finger and the periorificial area. So clearly more than one body site are affected. That's why it is generalized. Vulgaris means common. Okay, vulgaris in case of dermatology means common. Like acne vulgaris means common type of acne, understand like that. So this is characterized by scattered patches that are widely distributed. It's a common type of generalized vitiligo. And mixed means both acrofacial and vulgaris occurring together. Another type is universal vitiligo. Now, this is complete or nearly complete depigmentation, and it is often associated with multiple endocrinopathy syndrome. And this is a very rare type of presentation, and this is a severe type of presentation, because the patient doesn't have any pigmented area on the skin. A large part of the body is depigmented. Now, what is the problem in this type of patient? What complication can happen? If this person is
autoimmune defections.
Good. One is autoimmune problem, different autoimmune problem may happen. Good, very good. I accept your answer. But if this person is constantly going to outside, in the sunshine, what can happen? Yes?
Skin cell cancer, basal cell carcinoma.
Exactly. Okay, skin cancer, because there is no melanin. Remember, in case of patchy type of vitiligo, there is not no real complication like that. But this is a universal type of vitiligo. Large part of the body is affected, so the person cannot protect the keratinocyte because the melanocytes are already damaged. Okay, they're destroyed. The shielding effect of those melanin pigment, actually I should say like that, the shielding effect of melanin pigment on those keratinocytes are gone. It is almost like another condition, and I'm sure you know that. So what is the important differential diagnosis of universal vitiligo? Yes?
Albinism.
Remember? Albinism. Remember? Albinism. Very good. One of the one of the student in the Eastern University was having it. Okay, if you have noticed there or not. Okay, she was a patient of albinism actually. So she looks very white, very abnormally white than the other person. And when these albino go out in the sunshine, they should protect themselves. They should cover all the exposed part of the body. Otherwise, with the effect of that ultraviolet ray in the sunshine, they can quickly develop skin cancer. Similar type of situation here. Albinism, okay, is a hereditary type of condition, but vitiligo is autoimmune disease. Let's move further. Now, how to confirm the diagnosis? What is the lab study you want to do? Although the diagnosis of vitiligo generally is made on the basis of clinical finding, definitely any medical student or any doctor can diagnose vitiligo just by one look. Trust me, it is so prominent. Okay, biopsy is occasionally helpful for differentiating vitiligo from other hypopigmentary disorder. So you can answer biopsy may be done for ruling out differential diagnosis if there are any. But at the same time, to confirm those autoimmune diseases, I need to go for certain investigation. But remember, those investigations are guided by some clues from the history taking. I cannot do all these tests in a patient where there is no clues at all. When there are no positive symptoms, don't go for these tests. For example, to diagnose diabetes, I should ask certain questions like history of polyuria, polyphagia, polydipsia, recent loss of weight, okay, something like that. Just giving you an example here, okay. If these are present, then only go for the test. Otherwise, simply take history and keep the patient under follow-up. So these are the different conditions here. Now see here, thyrotropin testing is the most cost-effective screening test for thyroid disease. Thyrotropin means TSH testing. Okay, anti-nuclear antibody screening is also helpful, just to make sure there is a generalized connective tissue disorder is there or not. A CBC count with indices helps to rule out anemia. It is associated with which anemia? Which anemia we are talking here?
Pernicious anemia.
Very good. Pernicious anemia gives rise to megaloblastic or macrocytic anemia. Megaloblastic or macrocyte anemia. Okay. So when we do the peripheral smear, the size of the RBCs are bigger than the normal. And when I do bone marrow aspiration or biopsy, a lot of megaloblasts are seen there. So many of the students still get confused between macrocyte and megaloblast. Let me clear that doubt here. Macrocytes are mature type of RBC which are seen in peripheral smear, whereas megaloblasts are the immature type of cells present in the bone marrow. Okay, so these are a completely different type of term. We cannot see megaloblast on the peripheral smear. We need to go for bone marrow analysis. Serum antithyroglobulin and antithyroid peroxidase antibody can be done to rule out autoimmune thyroid disease, because these are the antibody which are produced against the thyroid. Screening for diabetes can be accomplished with the fasting blood glucose or glycosylated hemoglobin testing. Okay, but let me tell you again, it is directed by the good history taking. If you suspect these type of condition, then only go for it. Otherwise, they are not necessary, but keep the patient under follow-up. Now, if we take a biopsy, what are the histological findings? What we see there? Microscopic examination of the involved skin shows a complete absence of melanocyte, which will give you the diagnosis. There is superficial perivascular and perifollicular lymphocytic infiltrate. Now remember, these lymphocytes are damaging or destroying those melanocytes because this is an autoimmune type of condition. So they may be observed at the margin of a vitiliginous lesion or consistent with a cell-mediated process which is destroying the melanocyte. So this is an extra feature in histology, which will again tell us, yes, autoimmune mechanism is responsible for the destruction. Now, the final part is about the management. How to manage a case of vitiligo? See there. Treatment must be individualized and patients should be made aware of the risk associated with therapy. Now, you cannot use the same medicine for all type of people. That is called treatment should be individualized. And sometimes we use some powerful drugs like corticosteroid. Now, if this is a child, okay, a growing child, for example, 10 or 11 or 12-year-old child, especially girl, okay, or even the boys, and we use corticosteroid. What is the side effect of corticosteroid in that age? Yes, what can happen? What's the most important? complication or side effect I'm talking about here?
Early closing of plates.
Fungal infection occur.
Yes, I already got the
It may
answer.
cause stunting.
Very good. I already got the answer. Excellent. It will lead to early closure of the epiphysis, leading to stunting or decreased height. And no parents, trust me, no parents wants that. So we need to explain this situation. Otherwise, they will blame us later on. Why? Why did you use that that medicine, doctor? There are some other choices also. So why did you use that? So this is the big thing here. And we always, as a doctor these days, the practice is not that easy. You need to explain so many things to the patient party, and they should be convinced. Then only you can go for it. Okay. Now let's come back here. During medical therapy, pigment cells arise and proliferate from the following three sources. One of the sources is pilosebaceous unit, and remember this pilosebaceous unit is deeper inside the dermis. This pilo is hair follicle. Sebaceous unit is a sebaceous gland. Okay, both of these are attached with each other. So cells migrate from the external root sheath towards the epidermis, and then they will replace those damaged, melanocytes there. So this is one of the source. Second one is a spared epidermal melanocyte, which are not affected during depigmentation process. Some of them are still surviving or living there or normal there. Okay, all of them were not completely damaged. This is the second source. And third one, the border of the lesion migrating up to 2 to 4 millimeter from the edge. Okay, so those are the, for example, the normal cells, isn't it? There is a vitiligo patch, but from the peripheral area of the vitiligo patch, other part of the skin is normal. So those normal skin may migrate towards the abnormal site when we start therapy, and this may be the source. Now, what are the different types of treatment process? One of that is systemic phototherapy. This systemic phototherapy induces cosmetically satisfactory repigmentation in up to 70% of the patient with early or localized disease. This is a very important point we need to explain to the patient party. Okay, and this systemic phototherapy can be very nicely done at home also. We ask the patient to go outside in the sunshine and expose the part of the body to the sunshine. Narrow band ultraviolet B phototherapy is widely used in the hospital. Narrow band fluorescent tube with an emission spectrum of 310 to 315 nanometer and a maximum wavelength of 311 nanometer are used. This is called wavelength. Okay, so you don't need to know in this much detail actually. Just treatment here. This is known as ultraviolet B phototherapy, which can be done in the hospital. If patient do not have time to go for it, or if they cannot afford it, some people are like that, then we can tell them just to go out in the sunshine during the afternoon and expose themselves in the sunshine. Treatment frequency is 2 to 3 times weekly. Okay, but usually not on the consecutive days. This treatment can be safely used in children, pregnant women, and lactating women. There is no harm of this, and you can give Soralen before giving this ultraviolet therapy. Okay, we call this PUVA. And in which other disease we use PUVA therapy? We have just talked about that.
Psoriasis.
Excellent, psoriasis, very good. So similar type of a drug, PUVA. This is known as Soralen photochemotherapy. Involves the use of Soralen combined with ultraviolet A light. The Soralen is a drug which is given orally, and this will absorb more of the photo substance or the sunlight or this ultraviolet A or B. A is given in this sense so that it will be more effective. Another is laser therapy. Okay, laser therapy. another way of treatment. So this new treatment is an efficacious, safe, and well-tolerated treatment for vitiligo when it is limited to less than 30% of the body surface. Means, usually in case of localized or a bit, less type of generalized, means low body surface area is affected, then we can go for laser type therapy. But it is an expensive one. Now, the third one is a steroid therapy. Okay, steroid therapy. This systemic steroids, for example, prednisolone or dexamethasone or betamethasone, they have been used, although prolonged use and their toxicity are undesirable. Okay, quite a favorite question from the exam point of view. Why corticosteroids are not given for a long time? Because they can have a lot of toxic effect. The benefit versus the toxicity of this therapy must be weighed carefully and explained to the patient party. I am going to use this drug, but this drug can lead to those side effects, but it is a very powerful drug. It may really help regarding the vitiligo, but at the same time, it may cause you this side effect. We need to clearly tell that. A topical steroid preparation is often chosen first to treat the localized vitiligo because it is easy and convenient for both doctors and patient to maintain the treatment. But if it is a generalized one, we cannot give topical therapy, isn't it? Because a lot of tubes will be consumed at one time to apply everywhere. So it is not very feasible. So during that time, systemic therapy has to be used. In general, intralesional corticosteroids should be avoided because of the pain associated with injection and the risk of cutaneous atrophy. So orals are usually given here. Now, I already told you, for the adult, probably it is not of a big problem, even though it will cause some of the side effect. But in case of children in the growing age, especially near to the pubertal age, as far as possible, I should avoid it. What are the topical therapies then? See there. Topical tacrolimus ointment, 0.03% or 0.1% is an effective alternative therapy for vitiligo, particularly when the disease involves the head and neck. This tacrolimus is a type of immunosuppressive type of drug or immunomodulator drug, you can say. Okay, and so it may help the patient. On the face, narrow band ultraviolet B works better if combined with another group of drug just like tacrolimus. It is known as pimecrolimus. Okay, it is available as a 1% cream rather than used alone. So if we combine ultraviolet B with pimecrolimus, it will be more beneficial for the patient. These are the topical therapy. Now, some other groups of drug, okay, vitamin D analog like calcipotriol and tacalcitol, they have been used as a topical therapeutic agents in vitiligo. So these are some other choices. Remember, this type of drugs are also used in the treatment of psoriasis. They target the local immune response and act on the specific T cell activation. So they are also known as immunomodulator. Another type of therapy is very interesting one. This is known as depigmenting therapy. Now, depigmentation is already developed in the patient, right? So rather than repigmentation, we are going for further depigmentation there. What is the logic behind it? In cases of extensive vitiligo, the option to depigment that unaffected skin with topical drugs like monobenzone, okay, mequinol, or hydroquinone is way easier than the use of those drugs which repigment the area. So this is the basis. Let me repeat again. This is only done in extensive type of vitiligo, like a universal vitiligo. Only a small part of the skin is having pigmentation left, So why don't we depigment that area rather than, repigment the whole area? This is the concept, and these are the drugs. The removal of all the skin pigment with monobenzene is permanent and vigorous. Sun safety must be added for life to avoid severe sunburn and even the development of melanoma, because you are damaging the melanocyte by the use of this drug here. Okay, and depigmentation takes about a year to complete. So this is one of the option regarding the treatment. Now, finally, surgical alternatives do exist. Okay, there are certain surgical therapy. However, because of the time-consuming nature of surgical therapy, these treatment regimes are limited to the segmental or localized vitiligo